Okay, Chair Khan, it looks like we are live streaming. You can go ahead and call the meeting to order.
Thank you, Melinda. So it's 9 o'clock. We'll call the meeting to order. Let's take the roll call.
Sure. Leanne Mcallister?
Here.
Thank you. Chair Khan?
Present.
Thank you. Commissioner Roe Dugan? She's going to be just a little bit late. Commissioner Grady is excused today. Commissioner Van Houweling?
Here, present.
Thank you. Commissioner Bond was going to also be late. Commissioner Tyler Garner? Commissioner, I saw her on here. Commissioner Tyler Garner?
Yes.
Excellent. Thank you.
Thank you.
Commissioner Winkler?
Good morning, present.
Thank you. Commissioner Rubelid?
Present.
Thank you. And Commissioner Ralston? Okay, I do not see her yet. Okay, and then with the ex officio members, Director Richard Whitley?
Here.
Thank you. Commissioner Richardson, Barbara Richardson? Ryan High?
Present.
Thank you. And Laura Rich?
Present.
Thank you. All right, Chair, you do have quorum.
Thank you. So we'll proceed. Just a little comment, my usual, that in the interest of time for everybody, we'd like to wrap it up latest by 12 noon. There are some exhaustive subjects, or at least one of them. So we'll move along, and I would request everybody to focus on the individual question or opinion they may have, so that we can have everybody get an opportunity to give their suggestions, observations. Having said that, next item on the agenda is the approval of the minutes. Anybody has any additions or subtractions that they think need to be made in the minutes? Hearing none, all those in favor of approval?
Aye.
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 Any opposed? All right, motion carries. The item number 3 is the public comment. Do we have anybody in person, north or south, Melinda?
Let me check really quick. For those on Zoom, please press *9 to raise your hand. And I do see Patrick Kelly has raised his hand. Pat, please go ahead.
So a quick comment before we start. We have 3 minutes for each presentation, so kindly respect the time limitation so the others have an opportunity. Thank you. Please proceed.
Good morning. My name's Patrick Kelly. I'm the CEO of the Nevada Hospital Association. I'd like to address the recruitment and retention of physicians in Nevada. Nevada has a physician shortage. We're ranked near the bottom in many national statistics. We're 45th in the nation for active physicians, 46th for primary care physicians, and 48th for general surgeons. Nevada is below the national average in 34 of 39 physician specialty areas. This lack of physicians restricts access to care for Nevadans. Most physicians have opportunities to practice in other states. To entice them here and to retain the physicians we already have, we must provide options that meet their needs, which include joining an established medical practice, setting up their own medical practice, or employing them with income guarantees. New medical school graduates frequently seek employment. They're not interested in starting their own practice. Their focus is on a stable and predictable income and quality of life. Community medical practices are reluctant to hire many new physicians because it's extremely expensive. Recruiting involves coordinating visits, paying for transportation, lodging and moving expenses, and taking time away from one's medical practice. From an operations perspective, it takes physicians more than a year to develop a full patient panel and months for reimbursement to roll in. The existing doctors in the practice must float all these expenses. If the new doctor leaves, the practice can experience a significant loss. Community medical practices are reluctant to take such risks. Some think it's a great idea to have physicians practice at multiple hospitals. There's one big problem: logistics. Traveling to multiple hospitals each day eats away at valuable time that could be spent with patients. Many physicians prefer developing patient care plans rather than sitting in traffic. We have many questions about the PPC's proposal to limit physician employment. The biggest question is, who's going to recruit the new doctors to the state and employ them? The next big question is, what happens to all the doctors who are currently employed? Will their contracts be terminated? Will they leave the state? The physician shortage in Nevada is real. The PPC shouldn't do anything to make it worse. Please allow physicians to choose how they wish to practice in our state. Thank you.
Thank you. Anybody else for presentation or any written ones we received earlier?
Chair, I have not received any written public comments. And again, please press *9 if you'd like to raise public comment at this time. Seeing no additional public comment, Chair Khan.
All right, thank you. So we'll move to the next item on the agenda. Item number 4 for possible action is the reappointment of Stakeholder Advisory Subcommittee of the Peterson-Millbank Program for Sustainable Healthcare Costs, and suggested members list was attached. Now, the list was distributed to all the commissioners ahead of time by Melinda. I'm presuming everybody did receive it, had an opportunity to develop some opinions of their own. So having said that, I'll open this for discussion. The first question I would have is, did everybody receive the list from Melinda?
Yes.
Okay, so if everybody received it, I think we'll go in order, one commissioner at a time. Melinda, if you could go in a certain order so that everybody has an opinion about the two things. The one, the various stakeholders representing the various stakes in the system. If there's a reservation of the individuals representing a particular stakeholder's interests, then that's what we need to know. Otherwise, the individuals on the list are individuals representing an institution or organization, not in their individual capacity. Okay, let's proceed, Melinda.
Sure, Chair. And I did want to note that Commissioner Ralston is now present with us.
Okay, great.
So I will go in order of the commissioners. So first I will go to Commissioner Mcallister.
I have no comment or any reservations about any of the names presented.
Thank you, Commissioner. Chair Khan.
I have no reservations on this.
Thank you. Commissioner Van Houweling.
No feedback or comments either. I'm fine with everything that was presented.
Thank you. Commissioner Tyler Garner.
Good morning. No reservation, no comment. Thank you.
Thank you. Commissioner Winkler.
No reservation, no comment. I guess, well, actually, I take it back. Just clarifying that you reached out to these possible new committee members and they all expressed interest, and hopefully that would resolve our quorum problems we've been having before.
Correct, Commissioner. I did reach out and gauge interest. Out of the 13 that were submitted, I do have 2 that I did not hear back from. So am open to thoughts and suggestions on that. The 2 that I did not hear back from are the patient advocate for the American Cancer Society for Nevada, and the tribal representative, which I did just reach out again, asking for tribal representation this morning, and we'll keep you apprised of that situation.
Great, thank you. That's all I have.
Thank you. Vice Chair Rubelid?
I think it looks great. I have no reservations.
Thank you. And Commissioner Ralston?
Same as everyone else. My only question is just clarification. Just want to make sure that everybody who is on it currently and actively participating, they were allowed to continue on in their role as well, correct?
That is correct. Thank you.
Okay, great. Thank you.
Mhm. Excellent. And that concludes the commissioners present, Chair Khan.
Okay, thank you. So moving right along, the next item is the one that is going to take some time and deliberation. Item number 5 is for possible action, is review and discussion of possible bill draft request, subject and topics. So just FYI, we have done a similar process in the past when we submitted bill drafts in the past. So everybody had an opportunity as the commissioners to suggest various bill drafts that they are interested in being considered or looked at. Having said that, we received a large number of recommendations. In order for us to narrow this down, my recommendation was, in discussion with Melinda, let's look at the top 3, because we have the opportunity of recommending up to 3 bill drafts, to see which ones received the most recommendations for bill drafts, and at least start the discussion there in the top 3 that got the most votes, so to say, or recommendations. And then after those are discussed, if there is an opportunity for other items to be considered, and one of these 3 or 2 of these 3 are not supported by the commissioners after due deliberation, we can always go to the next in line in recommendations from the commissioners. And I would suggest that each bill draft of the top 3, that we take each commissioner's opinion like we just did earlier, Melinda, so that every commissioner has an opportunity to participate. So we can proceed, Melinda.
Sounds good. Thank you, Chair. So for this item, I just wanted to start out with a roadmap of the discussion for this agenda item. So first, we will briefly review the organization of the overview and detailed BDR documents. Second, the 3 commissioners who contributed to the BDR subject 3, topic 1, have provided some revised language, and I would like to give them the opportunity to present this information to you. Third, Commissioners Bond and Van Houweling would like to give a more thorough overview and clarification of BDR subject 2, topic 3. Then I wanted to introduce a panel of state subject matter experts in addition to the PPC ex officio members for you if you have any questions or need any clarification on a BDR topic. Next, we will review the results of the BDR poll together. Then based on the results, you may discuss how you would like to organize the BDR topics. And then lastly, based upon the discussion today, we'll talk about the August PPC meeting plan and the potential need for more than 1 meeting at that time. So in preparation for your discussion today to help consolidate the 15 BDR topics, I'm sorry, Michael, can you please, yeah, thank you, into a more manageable number and ultimately to a final 3. I had organized your BDR recommendations by associated subjects comprised of PPC goals as outlined in statute, which builds upon the work you've done previously and which continues to address patient access, affordability, and quality of healthcare in our state. I presented this information to you in the form of a PPC BDR overview document as well as a detailed document and asked for your review, comments, and feedback over the past 2.5 weeks. The overview document lists out all proposed BDR topics with their contributors under associated subjects, and PPC goals is outlined in statute. The detailed document lists all the same, but with the addition of the supporting documentation provided by the contributors and is brought up during discussion of the topics in past PPC meetings. Both documents are also included in your meeting materials today. I'm happy to report there were no issues, questions, or comments brought forward to me from the commissioners on this proposed organization of the BDR topics and these 2 documents. I'm extremely pleased to move forward into the next phase of our PPC BDR discussion. With regard to this process, I also ask the commissioners to please be open to the fact that some of the proposals put forward for consideration may not be most appropriate for legislative BDR. We all know that each of you really like the ideas you put forward, otherwise you wouldn't have chosen them, and that they are all truly important initiatives with merit. Please acknowledge that some of the proposed BDR topics will not necessarily make it as some of the final PPC BDRs, and please consider just being okay with that. With the 15 proposed topics, the PPC could still combine very closely related BDR topics into a single BDR final submission. However, please also consider a limitation on how many topics are combined into a single final PPC BDR proposal to the Legislative Council Bureau. With that being said, we'll move on to the next agenda item within this agenda. So this is the panel of state subject matter experts that are here for you today. I do also have other experts in state Medicaid who were unfortunately unable to be here today, but can answer questions if the commissioners have specific questions regarding to that topic. So we do have Dr. Antonia Capurro, Beth Slamowitz is also on, Ryan High, Richard Whitley, Barbara Richardson, and Laura Rich are here and available for you should you have any questions.
Melinda, if I may proceed with the top three or the number one and start deliberating. And as we move along, these experts can give their opinion on the validity or appropriateness and legal ramifications of each proposal or proposed BDR.
Absolutely. And Commissioner Mcallister, I see you have your hand raised.
Yes, Chair Khan, I'd like to go in the order that Melinda originally proposed, allowing the commissioners to present their language first, and then she was going to disclose the top three.
Which is fine.
Thank you, Commissioner. Thank you, Chair. All right, and now we'll move along to the next slide. Okay, and so the three commissioners who contributed to BDR Subject 3 Topic 1 have provided some revised language, and they would like to provide an overview to the commission on this language for this topic. Commissioner Van Houweling, I believe you're going to lead with an introduction of this topic revision.
Sorry about that. Thank you, Melinda. And I really like the format and the presentation flow of today's PPC. It's very easy to follow, so appreciate that. Yes, and this is really related to improving healthcare quality, part of our charter and mission for the PPC. And then one of the things is reviewing proposed enact legislation, regulations, and other changes to state and local policy related to healthcare in the state. So obviously that's under our PPC goal. As mentioned, topic 1 is really around looking at providers of healthcare and custodians of healthcare records implemented an interoperable electronic healthcare record system. So this is really about allowing patients to have direct access to the records in today's environment, and really following some of the CMS requirements out of the federal government, and just ensuring the state of Nevada is complying with that, but also if there's an ability to enhance those record access for patients directly and minimizing barriers will certainly help improve quality, outcome, diagnosis, speed of visits and providers. But really asking expanding the immunity for provider compliance with providing and receiving electronic records. This is really to encourage participation and alleviate some of the concerns around risk. Also, we'd like to also looking at PPC funding sources, exploring that to be able to allow access in every community in the state of Nevada, whether you're a major city or a rural area. But also encourage the exchange of information between systems. I know technology has gotten a lot easier and quicker, and some of these changes would allow for easier access, and just expanding on what we're currently doing in the environment around patient records and accessing those records for providers, but most importantly patients, so they can take them to their doctors to minimize visits, reduce cost, and out-of-pocket expenses. So that's one of the items that a couple of the commissioner and I, we had really good support in collaboration in this, Mr. Chair.
I believe Chair Khan. Chair Khan, are you muted?
Sorry, I was so sorry. So the observation I have in this one is, since it was very well summarized by Commissioner Van Harling, is any commissioner opposed to this as a matter of principle, or the gist of this subject to be seriously considered as one of the BDRs? And if so, perhaps they need to raise their hand and express their reservations, if any. Those who think this is an appropriate suggestion, then that's good enough. But anyone in the commissioners, if you could raise hands if you have any reservations, additions, or subtractions in your proposal.
Commissioner Mcallister, I see you have your hand raised.
Yes, I'm wondering if any of our subject matter experts have any information on similar efforts in out of state and how those have or have not worked well.
Anybody in the subject matter expertise want to speak? None. I'm not an expert in this, but I can say the reservations that have been expressed in the past over the years, this is important and crucial. It's always boils down to quote unquote HIPAA. And how does one protect this from HIPAA perspective? And Commissioner Van Harling, do you have any thoughts on that? What work has been done to avoid any HIPAA conflicts?
Thank you, Chair Khan, and thank you, Commissioner Mcallister, too, for some additional questions. With UMC and many of our healthcare providers have electronic health records now, and part of just normal operations to be able to conduct business. And with the way that technology is, we wanted to ensure that that HIPAA is protected, but also that patients can get direct access. Often through our current exchange that we have, it's really provider to the exchange, and we want to make sure that the patient is able to kind of dial in and access portals through HIPAA securities, obviously, and we all have those currently with secure two authentications or other direct protections for those patients to ensure that their medical records. But I think really what the goal with this is just allowing a little bit more direct access for patients versus going through or not having access via the current exchange, and making a little bit more robust and ensuring that patients can go directly to their provider. And they can today, but it's a little bit more cumbersome, and we want to make sure they can do it in electronic format versus paper copies or requesting records and other things. So I think the key is putting some meat around direct access for the patients, for their protection, to be able to be mobile and be able to transition from provider to provider in an easy way to be able to create some access.
Thank you, Commissioner Van Harling. So anyone else, Melinda, who would like to opine on this?
Actually, Chair Khan, I did want to also clarify for the commissioners that this language that you see here was the language that was included on the poll. So all the commissioners that completed the poll, this is the language that was included there. And then I'll go to Commissioner Vice Chair Rubelid.
Hi, good morning. I just wanted to clarify from a federal perspective, the patient access and interoperability rule does require that we have standardized interfaces. As a health carrier, Medicaid is compliant with that rule. We do provide an app for Medicaid recipients so that they can look at their claims history, provider directory, pharmacy PDL, those sorts of things. The big gap, though, is that we do not have a robust claims, clinical claims or clinical data repository. So really what we're looking at is trying to connect EHR to EHR so that the patient has direct access to share their clinical records with their providers at the point of care. So that's really the intent here.
So if I make quickly comment based on what Commissioner Van Hollen also pointed to. And Commissioner Van Hollen, you can chime in if I understood it correctly. You were suggesting that the records be patient controlled, patient managed, so that the patient has authority when and if he or she shows up at a different facility or an organization, electronically it can access his or her record, or a family member, if they're going to the emergency room, will have access to get into their password and get the information out. And the patient controls it rather than the organization or the institution. Is that a correct understanding?
Correct, Chair Khan. Well, a couple of things. Obviously, there are, if you're within a particular system or provider's office, there, as was mentioned, I think by Sandy there, is that you can get direct access, but also allowing for a little bit more robust exchange between different systems. And our current exchange has that repository, but the patients aren't able to get direct access to that. So say you could have Cerner, you could have Epic, you could have McKesson, you could have Athena, but bringing all that together is a bit of a challenge. So we certainly want to look at that and provide, the current exchange brings that together, but only providers can see that. And I think the control is we want to put that back in the patient's hands to be able to have access to it. That's one thing, but also allowing, ensuring that we're following all the CMS rules related. Pretty good job, but just ensuring that you can have that front to back patient care visits, whether it's labs, radiology, imaging, diagnostic things, nursing records within your current electronic health record in the state, regardless of what your provider is. So I think that the underlying thing that I would like to convey is ensuring that patients have access to that, whether it's within our current exchange, but also within the providers.
Got it. All right. Who else is on the system wanting to opine?
Commissioner Winkler, please go ahead.
Yes, thank you. And I just wanted to echo what Commissioner Van Hollen and Vice Chair Roybal had shared, that these are federally mandated requirements of interoperability, but also just to directly address the HIPAA concerns. The CMS requirements do have certain, they do have standardized ways to ensure protection of that health information. And there's, again, all the HIPAA rules will be protected. This is just about that access point. There would still be those layers of protection that would be involved with any digital software.
All right, thank you. Anybody else wanting to opine on this topic?
Seeing none, Chair.
All right, thank you very much. If no more opinions on this subject, this would be one proposal that seems like everybody is in consensus to seriously consider this topic as we narrow things down on the BDRs. Next topic.
Thank you, Chair. With this topic, I know that Commissioner Bond is going to be late. She's probably going to be here in another 30 minutes. And I was wondering if possibly Commissioner—
I propose, Melinda, maybe go to the next items and she's the presenter or proposer of this. So we can table this for the time being for half an hour or so and go to the next one, subject 3 or topic 3, and then come back to this once Commissioner Bond is here.
Sure, that would be fine.
Okay, so let's proceed with the next one, only to come back to this.
Okay. All right. As you all know, the PPC must put forward its 3 BDR topics no later than September 1st. The goal of our meeting today is to further discuss and organize your individual recommended topics, as well as to agree to move forward under this approach. You do have the ability, and it is reasonable, to group together similar proposed BDR topics, but again, please consider not doing so in excess. So in the interest of efficiency during today's meeting, we deployed a web-based poll to all voting appointed PPC commissioners. This poll was developed to ask for the top 3 topics each commissioner is most passionate about. The poll results will be reported as anonymous and shared in aggregate today. This approach should allow for topics with a higher number of responses to move forward into a more formal voting discussion of the PPC in August. It is proposed that any BDR topics showing 0 to 2 responses from the poll to be set aside to discuss at a later time. This will allow for the commissioners to prioritize discussion on BDR topics with higher responses during the meeting today. Again, I agree that all proposed BDR topics are important and have good merit. I'm very impressed at the number of topics that you all have thoughtfully brought forward given this young commission. However, in due diligence to the public and the legislative process, not all 15 topics can be chosen to move forward into a PPC BDR in the 2023 legislative session. My hope is to facilitate a discussion leading to consensus for the PPC to move forward strong legislative recommendations in support of the PPC goals for the betterment of patients in our state, and the BDR poll is a helpful tool in this process. So with that, Michael will move forward. Okay, so poll results. All right, and so this is slide 1 of 2. So here we're showing all of the results for all of the topics. And then after that, we'll move forward into a deeper dive of the topics that have the higher number of responses. So this is a summary of the topics and the responses that they received. And as you can see there, topic 1 or subject 1, topic 1 has 4 responses, being a high number. And then additionally, subject 2, topic 1 has 5 responses, also being a higher number on this slide. Let's see. And then is it all right if we move to the next slide?
Yep.
Okay, so this is the second slide showing the summary. Again, on this slide to note, subject 2, topic 3 has 4 responses. Subject 2, topic 6 also has 4 responses. And subject 3, topic 1 has 5 responses. So those are the higher number of responses for this summary slide here.
Narrow down our next step in this process on these top 3 and then continue with the others once these 3 have been discussed and deliberated on?
Absolutely.
And Melinda, if I might clarify, so we don't really have a top 3. We have a top 5. There were 5 that generated 4 or 5 responses.
Yep, you're right.
Okay. And then Michael, I believe we went into, we have a slide for the higher number responses, correct?
Right.
Excellent. All right. So these are the top 2 with 5 responses because the other 3 had 4 responses. So Chair Khan, these are the top response topics from the poll, these 2 right here.
Let's take subject number 2 and then 3. And then like it was pointed out, depending on the others that received 4, we'll take those with 4 responses.
Okay, and to open it for discussion?
Yes.
Okay. Okay, commissioners. So for subject 2, topic 1, to codify the Nevada healthcare cost growth benchmark and to include.
The second, Melinda, if I may, the subject 3, topic 1, the second one here is the requirement for providers of healthcare, custodians of healthcare, interoperability, etc. This one we just deliberated on a few minutes ago with Commissioner Van Holling's input, did we not?
Correct.
Okay, so let's do the topic 1, subject 2, and then skip subject 3 unless somebody has any additional thoughts on subject 3.
Will do.
Okay.
Okay, so to codify the healthcare cost growth benchmark and to include a measure and report on primary care spending, is there any discussion, questions, concerns, clarification from any of the commissioners on this topic? Commissioner Winkler, please go ahead.
So I'm interested in that second part, the report on primary care spending, because I believe in one of my, well, in the prescription drug affordability review boards, there was also some work done in like Rhode Island that showed that it had the most benefit when it was tied with investing in primary care infrastructure. So I am interested in that, and maybe perhaps there's a way to combine those topics, or at least the aspects of them. That is all.
Thank you, Commissioner.
Any other comments on this?
Vice Chair Rubelid, please go ahead.
Yeah, I just wanted to express my agreement and support of what Tyler just said. I think that makes a lot of sense.
How about those who are not a part of these 5 responses, the other commissioners who didn't choose that as one of their top priority? Do they have anything to add or subtract from their thought process? Hearing none, I guess.
Seeing none.
So this is one of the subjects that at least 5 people want considered as one of the BDRs. Just keep in mind the exact language will have to be tweaked by the legals, etc. when and if we get to this.
Correct.
All right. So the topic number 1, subject 3, as I said, we had just deliberated at length. Unless somebody has any additional compelling, contradicting recommendations, please speak up now.
Dr. Tyler Garner, please go ahead.
Thank you. I just had a clarifying question. I think I alluded to it in the chat previously. You noted that there's already a federal mandate in place to support this particular policy. I'm wondering if there are others who have already considered this, or if it is in the consideration with any other committees, commissions, or legislators.
And our experts, do they have any input? The experts are silent.
And this is,
I'm sorry.
go ahead.
I would just say we don't know yet. I haven't seen anything, but it's possible.
So I can comment briefly on this. So the federal mandate is still technically and actually practically in limbo. Even though there is a federal mandate, there was a deadline, if I remember correctly, way back after with the next number of years. That has not happened. And Commissioner Van Hollen can correct me if I'm wrong. Those deadlines have come and passed, I think, already, or almost close to being passed. So the question is, who's going to enforce it or implement it? Experts have any opinion?
And Chair Khan, just maybe if I could, part of our submission to this particular topic is looking at revision of NRS 439.584 related to the HIE and others identified, but in just ensuring that this recommendation that we're putting together, and as you mentioned, it will need to go to council for actual language to be able to be written, but we've given a lot of good suggestions, but ensuring that it's compliant with both current and the federal laws that may be in play or not in play. So just maintaining that language that supports the exchange of patients' information electronically, both on the federal and the state side. So we do want to make a little bit of a revisions to NRS 439 to ensure that we are meeting those needs as was mentioned prior.
Okay, that sounds good. Any other comments on this before we move on to the third item?
Yes, Commissioner Ralston, please go ahead.
Oh, thanks so much. I agree with everything that all the commissioners have said about this topic, but now seeing that there is a majority of respondents to move forward, I think as this conversation continues, I really would like to see the specific revisions of NRS 439 and what the proposal is, in particular, the effects that this might have on our state DHHS operations, and making sure that they have an opportunity to weigh in, because surely if this gets to a bill draft, the legislators are going to be asking these questions, and the funding and basically the logistics on how this is going to operate in our state. So just want to make sure that they have an opportunity to weigh in, really want to be able to see the specific revisions and also want to make sure that as this moves forward, that there is clear and concise language about patient access. And I know that the intent is for it to be patient controlled and managed. I just think it's imperative to make sure that that language is put forth in the bill draft request process.
So that's a very good thought process, Commissioner Alston. I'm presuming, and I'm pretty sure the experts plus legals will put their heads together and come up with the language that should incorporate the thoughts that you have just expressed. And it'll come back to us, obviously. And if there is some missing piece at that time, hopefully in August meeting, we can add to it and tweak it further to make it very concise and precise based on the intent of the commissioners.
Yes, great. Thank you so much, Chair. That's exactly what I wanted to just make sure that we started that sooner than later.
Yeah, I think it should be whatever we narrow things down to today. I am hoping that in August meeting, we'll tweak it as best as we can after input from the experts.
Wonderful.
And
Thank
Chair
you.
Khan, if I could, through you, just address Commissioner Ralston's question. And it's a great one, too, because one of the things that we want to ensure that we at least explore providing funding for education, access, ensuring the interoperability, but also ensuring all the HIPAA concerns that are there that would need to happen, but also looking at some of those emergency waivers that we've had under exchange of patient information that could be tied into. So we certainly want to address that as we continue to refine this language, but knowing that we do not want to put the Department of Health and Human Services in any budgetary constraints. So one of that pieces that we would like is the education, advocacy, access, but also ensuring that there's funding support for that as well. So I think we agree with you on that, Commissioner.
Thank you so much.
Okay, anybody else? Any thoughts?
Yes, Commissioner McAllister.
Thank you. So I hear from patients often that they go to see a provider in Nevada, and because that provider is not VFC, they don't have to put the records into WebIZ. And so when I read this bill draft, so will this require those providers mandate that all healthcare providers and records, that everything now would have to go into WebIZ? Because right now there is a lot of missing information in the systems that we already have set up for patients.
So that's a good point. As the experts chime in before our next meeting, they will have to look at all these aspects of it, including what Commissioner Van Holling alluded to is regarding the fiscal impact also, whether it's for the state or the individual practitioners or institutions in the state. So all of that will have to be looked at. Fiscal impact will have to be reported to us. And how is that fiscal impact, if any, is going to be taken care of? So yes, these aspects will have to be reviewed by the experts and come back to us at our next meeting. Any other comments?
I'm not seeing none.
All right, so let's go to the next subject, I guess.
Sure.
The next are those with 4 responses, I suppose.
Yes. So there were 3 topics that received 4 responses. So this first slide shows the first 2 with 4 responses. So the first one being subject 1, topic 1, to explore opportunities to provide basic health care coverage to infants, children, and young adults up to age 26 who are ineligible for full Medicaid coverage under federal law due to current residency or immigration status.
Okay, so let's go by with each commissioner thoughts. Those who have proposed this, or is their priority, before we get to them, are there others who have reservations about this or thoughts on this? And if there are reservations, what are those reservations?
Commissioner Van Holling?
Good, and again, I really like this process, and we've got so much to choose from this go around, and there's definitely a lot of action related to our choices, and it's nice to see the consensus. I do want to ask and not to put our experts on the on this one, but just the implementation, I know there's a lot of process on determination on financial records, bank records, employment status related to the Medicaid coverage in the state of Nevada. I'm just curious logistically, how do you validate some of this when you're looking at income, because it is a poverty sliding scale type of program. So I'm just curious on the execution of that from the department and some of those caseworkers. But then I know that we'll have to have a fiscal impact on this, but is there any estimates on what this could increase the budget related to the state? I know that last I looked, there's still probably around 10% uninsured in the state of Nevada, even though we're an expansion state, which I'm very glad we are. And I think that's been a game changer in providing a lot more access and availability and getting care in the right setting. But I wonder if some of our experts had any opinions on some of the proposals and costing this out. I mean, so how do you validate so you can ensure you got a good application to make sure somebody's eligible, but also how much would this potentially add to the Medicaid program in reimbursement to facilities?
So to carry your point a little further, Commissioner Van Harling, it's a lot more complex than what we see in this brief language here. You have people who are tourists, you have people who are visiting, and if they're not covered, how does that get taken care of? We don't want to become a medical tourist attraction where everybody knows Nevada provides healthcare irrespective of our immigration status. Let's go there and get our elective work done in Nevada. So what you raise is a very crucial point as to the criteria under which who becomes eligible, if at all. So the experts, could you have some opinion on this?
I see Director Whitley, you have your hand raised.
Yes, sure. I can speak a little bit to this. And Commissioner Van Halling's question was framed towards eligibility, and our eligibility. We were one of the first states to integrate eligibility with SNAP, Medicaid, TANF, WIC. It's a sound process that already reviews to standards, and so that there would not be a additional cost to integrating this eligibility. They also do the eligibility determination and referral for the exchange. And so I think that it is a system that's already intact on eligibility. Separately, the cost for actual coverage, but we already have like mixed families where maybe one family member is undocumented and or a parent, and so we already work in this space. So there is not a challenge here in the space of eligibility. In fact, it's an integrated system.
Thanks, Director Whitley. You well said, and your team's always been cutting edge and does a great job. So thanks for answering that question. I just don't want to, if the process was going to change, but it sounds like you've been dealing with this for a long time, and I appreciate you bringing up the mixed families and the integration, regardless of their status. So thank you, as always.
I would just add that I think what this actually helps our state do is have a building block that we could expand. You know, a lot of times people enter into health or social service request lines for a service and aren't aware that they're eligible for other things. And so we're currently working with some of the larger counties to incorporate or integrate eligibility with some of the local housing and other services they provide. And so this would really go along with that work, and really, I think, could be transformational for individuals and families who are struggling, you know, with some of those other determinants of health, like housing, transportation, electricity, some of those things that the welfare division already does eligibility for.
Could I, Chair, through you, could I ask Director Whitley one more question that just came to mind?
Yes, please.
And maybe a little bit of a plug for the physician providers, but Director Whitley, do you foresee, if this is approved and passed and moved forward, I'm not sure if all commissioners know, but there is a program called Emergency Medicaid for particular diagnosis within facilities. Facilities are reimbursed, but typically the provider is, the physician's not. What do you foresee this happening on the emergency Medicaid side? That directly go down, or is that program still there? How do you see this interacting and intertwining with the emergency Medicaid status that we've known and delivered for many, many years? If this is passed and approved, what happens to that program?
This is Richard Whitley. I don't see any change. I mean, we follow the CMS rules and the allowances for that, and this would in no way restrict that. If anything, it would perhaps offer a touch point for that individual or individuals' families to have access to other services that they may be eligible for.
So a quick comment on that. I'm glad you brought it up, Commissioner Van Holling. We deal with this all the time in the hospitals. The emergency Medicaid itself is very restrictive. It covers acute care, and in an ideal setting, if the patient is in the intensive care unit and critically ill, that is covered. If they are on the regular medical surgical floor, the coverage stops. Correct me if I'm wrong on that one, Mr. Whitley. But having said that, the physicians who are taking care of these patients do not, and underline, do not get reimbursed. That also Commissioner Van Holling brought up. And I appreciate that, being a provider myself. They are taking care of these very sick patients and not being reimbursed. And even the hospital has limited reimbursement for a limited type of medical conditions. So Commissioner Whitley, what are your thoughts on this, budget-wise?
Well, I don't believe this would change. I mean, we already are fully maximizing the CMS rules related to emergency. And so certainly the fix would, if reimbursement were the goal of the facility and the provider, that would have to be general fund. We wouldn't be able to do something differently with Medicaid related to this population. But we're already providing this. It's an issue probably that one piece you left out is it's really hard then for hospitals to appropriately discharge without a payer source. So if somebody was, had an accident and needed rehabilitation or transferred to a skilled nursing facility, it's very hard for the hospital, who is required to do an appropriate discharge and is actually regulated to that, to actually find a provider to step down the services. That is a challenge. This is an issue unto itself that is probably worth at some point pulling the data on, in terms of what burden we see. Some border states like Arizona have like large budgets where the burden has fallen on rural hospitals when someone's in a car accident, but this bill proposal does not change that emergency care and the challenges that are in there. But that issue it could be an area to take a look at a future meeting with, and better understanding where the burdens are, and then where the perhaps opportunities are.
So if I may follow up.
As you said, Director Whitley, too, this would ultimately expand those services just beyond the acute care episode that, and hopefully it'll provide some population health or preventive care that avoids some of those. Now, we know most of those are on the delivery side, but I think you early on said that this could mitigate some of the other need for higher cost care if properly cared for in the right setting. So I think you said it extremely well. And do we get any, if we expand this, is there federal dollars that comes into the state budget to match, or is this just all general fund, as you mentioned? And then I'm going to stop asking, because I love the economics of all this. I want to make it work, but I'll leave it there.
I would defer to Dr. Capurro on whether or not aspects are reimbursable. A lot of, like the way CMS has designed the eligibility for some of these expansion and the rate of reimbursement is different. So we definitely, on every bill that touches Health and Human Services or Medicaid, we do a fiscal note on it. And so we would, on this bill in concept, we would be doing that and sharing that with this group, what the cost would be. Also, then on the other topic we were discussing, I just think that it happens enough in our state where the burden and the challenge for appropriate discharge occurs that it might be worthwhile to actually do some analysis on the impact. I hear it by onesies with a hospital who has a challenge with a discharge and getting anyone to take, and we kind of piece together things sometimes, but the burden shifts. And I think it's worthy. It's a problem worthy of exploration, but I would just separate the two.
So, I mean, this is an important subject from my perspective also. Could we have some fiscal impact analysis at our next meeting, at least preliminary fiscal impact analysis for providing, because it becomes a Band-Aid if you just cover the emergency acute care in the hospital, and then the patient's left to nothing after that, and the hospitals are eating the costs of this so-called emergency coverage, which is really also a very limited coverage, and the doctors are not reimbursed. So at least I would like to see the fiscal impact, because if we can fund billions of dollars for education, which is crucial and very, very important, healthcare is just as important, in my opinion, to find resources if it is coming from the general fund, and the federal government has no major restrictions on that, then I would like to know that. And then we need to figure out a way of providing those resources to the state to do this coverage if health of patients and patient protection is important. And patient protection means all patients, not patients who are insured only.
Thanks, Chair Khan. I do notice, Dr. Capurro, you have your hand raised.
Yes, good morning. I'll address the financial questions that were asked. I think this is a fantastic topic and truly transformational for the state. I just wanted to mention that it's my understanding that if this is established, it would be a Medicaid benefit that would not be federally funded. So it would require 100% state funding. I did want to mention that we have submitted, it's a little bit early, but we have submitted a state ARPA request to conduct a study on this. We have proposed hiring a vendor who would look into this and provide us with more information on how this benefit would be provided, what the population would look like, how we would establish long-term sustainability for these services, and then answering some of these questions about what type of package of benefits would we look at? Would we look at a cap on spending to control state costs? Are there other sources of funding, private dollars perhaps, or local funding that we could braid and blend to provide coverage for this population? So I think we have a lot of questions about this and maybe what that would look like. And I think some of that would be needed in order to create any kind of fiscal impact summary, because we need to know exactly what type of benefits would be provided.
No, I understand that very clearly, and you raise a very important point. That's why I think, given the fact if we are going to consider a BDR, our time constraints are very rigid. And I know it's asking a little bit too much to have analysis, but at least a reasonable, minimal analysis of the cost impact and sources and what kind of coverage would be covered and which providers will be covered, et cetera. It becomes involved. Don't want to go into that today, but I'll be available to give my input to this entity or individuals who will do that. If we can get a preliminary impact report, that the areas you mentioned before our next meeting, at least as a starter, I don't expect them to give a deep dive analysis, but at least a preliminary analysis.
I can take that back to our team. We may have to make some assumptions on what this would look like, but we can bring that back to you.
I would appreciate, we'll put it on the agenda for next meeting. Whatever you have available would be helpful.
We will do. Thank you.
Any other comments, or we can move on?
Yes, Chair Khan, I do see Commissioner Mcallister, you have your hand raised.
Thank you. Yes, and in response to you, Chair Khan, the BDR proposal is to explore these opportunities, to have the state take the time, the resources, and the investment to explore and answer those questions you have. So to put pressure on to answer those questions now is not actually material to what the BDR proposal is.
No, I agree. We are trying to explore, the sooner the better. So it's a first phase of exploration at the next meeting to get, as I underlined, preliminary assessment. And that will be preliminary. Nobody is going to be held responsible for that. And it may go on to the meeting after that and that. And whether we'll get to a BDR language based on the assessment before our deadline, I don't know that. But if it happens, great. If it doesn't happen, at least the groundwork and homework would have been done for next phase. Any other comments from anybody else? If not, we can move on, or is there somebody else?
Sure, Chair Khan, I do see Vice Chair Rubelid. Go ahead, please.
I just wanted to point everyone to the detailed BDR document that was provided. There is some information on page 2 specific to the funding of this and what California experienced that might be helpful.
Yes, thank you. I think our state people can use that as a baseline to get to some assessment and analysis. Anybody else?
I'm not seeing any Chair, I'm sorry.
Move to the next one.
Sure. This is actually perfect timing because I did notice Commissioner Bond has joined us. So I would like to give the opportunity for Commissioner Bond to present subject to topic 3 to clarify to the commission and joined by Commissioner Van Houweling. So Commissioner Bond, please go ahead with this topic.
Thank you. And good morning, everyone. I'm sorry to have been late, but it's been
no problem. We held this item till you joined.
Very thoughtful. Thank you. This is a request to prohibit corporate practice of medicine very clearly in state statute. And apparently I missed some public comment today from the Nevada Hospital Association representative, which may just help identify why this is an issue and why we should be addressing it. So through the corporate practice medicine doctrine has long been established in Nevada through various AG opinions. And during my time on the Nevada legislative scene, which has been through both the Culinary Health Fund and the Health Services Coalition, there's been at least 2, maybe 3 efforts to actually end the prohibition of corporate practice of medicine. So clearly it exists. And there's exceptions in the statute for what can and cannot be considered corporate practice of medicine. But the conversation even right now is a little murky, right? So this was an attempt to change the statute NRS to just make sure it's very clear that the policies and interests of the publics and physicians in the hospitals are aligned around one law. And this became an issue last session. I was specifically told by the Nevada Hospital Association representatives that corporate practice of medicine is prohibited and against the law in Nevada. So this needs clarification. The reason it's a concern is even the Nevada, what happens under corporate practice of medicine is the hospitals or facilities themselves can hire a doctor, which is much different than provide privileges to the doctors. So if you've got 10 doctors that do neonatal pediatric work in the community, and those doctors generally would have privileges at all the hospitals to do whatever pediatric neonatal work is needed at that hospital. That's privileges. What the corporate practice of medicine threat is the hospitals actually hiring those doctors. So then those doctors are taken out of the community to work at all the hospitals and are really only working at one hospital. And that has created some shortages that have intensified the shortages that we already have. And the American Medical Association has raised this as a public policy concern for a long time, because they are concerned that if you work for a corporation or you work for a hospital, your own patients' interests may not align with the physician's obligations to the facility instead of his patients. So they've had concerns, but it's been a longstanding issue in Nevada that we had corporate practice of medicine. I'm very interested that the Hospital Association said something to the contrary this morning, apparently, and I'll go find out what that was. I don't want to put words in their mouth, but that's the attempt. The attempt is to free up, making sure doctors are available for all of the facilities and that we're not creating more consolidation and winners and losers in the healthcare system by having them hired by one facility.
So,
They should still have privileges everywhere, though, Dr. Khan, which I think we talked about last time. This ensures that the facilities are not being withheld, any sort of access to the physicians, which they critically need, because the privileges program is the program that makes it all work.
So my question then would be, what happens in a situation where a particular entity recruits a physician, like it was alluded to earlier in the hospital presentation, is that they used to at one time sponsor the physician way back and guarantee income, guarantee, etc., to entice them to move in the state because of shortage of physicians. And that, I believe, is not happening anymore because at some point, conflict of interest law came in, and that practice generally in that exact format was foregone. Having said that, if the entity recruits a physician with some understanding that their hospital or entity that is recruiting them would be the priority practice location for this physician, and yet the physician could have privileges elsewhere. I understand it is happening right now where certain entities have recruited physicians with a contract, but yet they are having privileges in the other hospitals, but the bulk of the practice is at one particular entity.
Well, I didn't hear, I'm sorry, because I was late. I did not hear the public comment from the Hospital Association, and I would really like to go back and hear that. And you've been involved, Dr. Khan, as much as anybody in this commission on the practices of the physicians in the community. So maybe we can have more finite conversation about exactly what you're asking. I don't know. I don't believe that there should be a situation where a hospital can hold a physician's practice in the state, solo. I don't know if these mixed things you're talking about. I don't know what's happening in the market. I need to go learn that. But I would like to use the focus of the PPC to make sure that physicians are freed up as much as possible to be able to practice everywhere and help eliminate shortages that have started to occur. I think the exception and the exception always, and I think what led to this confusing, AG opinion and this long road is there are academic institutions that absolutely have to hire the physicians. The physicians are teaching and they have to work for the facility. And I think there's also a very clear goal, and always was, that a public hospital would be able to hire their physicians because it's the way that their practice is set up, and it's the only way that they get the training and the residency programs that they need. But I think those should be exceptions, and I don't think those exceptions should be extended to the rest of the hospital systems because of the shortages that it creates. And one hospital can hire a doctor that's doing really financially well, and then the hospitals that really need those doctors that are taking care of low-income patients then have no access. So that's the problem I'm trying to address. Many states have a prohibition on corporate practice of medicine, many, and we can get that list too. I didn't do that work yet, and I'll get that to you. But it's a pretty simple BDR, but I'm sure, as you're pointing out, Dr. Khan, it's a pretty complicated issue that we need to work on.
It is. So I think we need to hash it out with some dialogue across the aisles from all sides. Also, my question to you is, are you suggesting in this corporate practice of medicine, because there are just about every managed care organization in the state also hires physicians that work exclusively with them, especially in the primary care field, where there is a shortage of physicians more than the specialties, but even in the specialties. So in your thought process, are you considering those managed care organizations, the large ones in the state, that hire their own physicians more and more?
I think primary care doctors have always worked for one facility. They don't usually, some might have privileges in other hospitals, but in general, it isn't the same situation as these specialists in hospitals that are trying to make sure that patient access exists. So it's a second good question. We should start a list, Dr. Khan.
Okay, so we'll take some offline, go over some lists and have some experts answer those questions for us.
Yes, and I need to go hear what the hospital association is saying as well.
Okay.
But is there anybody else that can help here?
So I do have a couple of hands. So I see Commissioner Mcallister, you had your hand raised first. Please go ahead.
Thank you very much. And thank you, Commissioner Bond, for raising this super important topic. I think it's really worthy of our discussion here today. My question to you is, do you think a ban on non-compete clauses would have the same effect that you're trying to achieve? Other states have done that doctors, then they don't have a non-compete clause, so they can kind of take jobs and moves around however they and the market and patients need.
I don't know. I think that's a third issue we should look at. I'm not sure that it meets the same goals as our longstanding corporate practice of medicine prohibition. I think it weakens the system, but I'm saying that without actually knowing what I'm saying. So if you'll entertain me a little bit, Commissioner, I will take that issue as well.
So I may answer that question. The non-compete clause that exists, people, groups, private practice groups, etc., who recruit and hire physicians, they all have a non-compete clause. It went in one particular case I'm aware of many years ago, the physician who was being asked to not practice within the 3-mile or 5-mile zone of the area of the entity that hired the physician was challenged in the court, and the court ruled in favor of the physician that non-compete was not effective. However, in the large number or majority of the cases, the legal entities have upheld the non-compete clause with the caveat that the physician knew what he or she was signing on to and signed it knowingly, therefore is a part of that decision. So that's just an FYI.
And then Commissioner Van Houweling, please go ahead.
Yeah. Okay, I appreciate the dialogue and the conversation, and I'm going to try to summarize what Mr. Kelly said about that in his presentation, but I think it was a combination of Nevada's very short on providers, and we're at the bottom as far as patients to providers, which was one point, and then the other point was some income guarantees, and then limiting those. I have a little bit of a different opinion on, and I'm familiar with income guarantees for providers. And it's a way, it's a CMS way to be able to bring somebody in, but also not violate any Stark rules or inducement rules to admissions. Usually when you put those income guarantee packages together, you're basing it off of a community need within a certain radius. And typically, because Las Vegas is relatively small, we're underserved in many of our areas, especially as we grow. So I think, this definitely needs to be looked at. We all have to be very honest that we have very short supply of pediatric surgeons. I remember when I first took over UMC, we literally had 3 pediatric surgeons in the entire valley. And if I decided, or anyone else decided, to hire those and only have them operate at one facility, and they can kind of pick and choose on who they care for, and if it's not a requirement such as trauma or burn or any of those areas, it could really limit the access to the rest of the population, and not to consider their financial status. I also would like to point out that we are the furthest behind on GME slots. I think we have less than 500 GME slots, and they're mostly in the bread and butter, primary care, mental health, general surgery, OB. They're not in some of these very high-end specialty areas such as thoracic, vascular surgeons, cardiac surgeons. So I just think we need to ensure that we're following the current laws, and there's a lot of current laws on the books, and maybe we can have some expertise to ensure that we're complying with that, but also just ensuring that we're just not plentiful in providers, and especially the subspecialties, that really creates the issue that we can just grab them off the streets and only hold them to a certain population in the community. I mean, I think until we can get more GME slots and we can get more specialties and residents, I mean, right now anesthesiology is an issue. You know, it's a major issue in our community. It's an imminent crisis. So if we did not have the availability to those at every facility, it would create problems. So I just would ask that this be looked at on the crux. But when we take things out of the market and out of play, everybody loses. Only a certain group benefits, and it's, as Ms. Bond said, it's not in the urban core or not in our underserved areas. It's certainly not in the rural areas. So I just really would like to look at the existing laws, just ensuring access. And this is, if we take off our hats and everybody really looks at our charter, is providing more access to all the patients in the community. And when you take things out and you not have it available for everyone, and I would argue too, and I think Mr. Kelly's right. I mean, physicians practicing at 7 to 8 hospitals is tough, but they also have some choice to do that too. If they're in private practice and they say they want to work on the northeast side of town because that's all they have in their capacity, and we want good outcomes, quality, there's still that option. So you don't have to be on every hospital staff in the valley. And I think you're seeing a lot of that movement change to say, I can only work on certain quadrant as the community grows. So I just would hate to take something out that's been working well for so long and put others at risk. So this is my comments. And I apologize, Mr. Kelly, if I didn't summarize your words, but you'll have opportunity at the end. And maybe you can summarize back for Ms. Bond the Hospital Association's position.
Thank you. Any other comments on this before we move to the next item?
Can I just wrap up, Dr. Khan?
Yes.
Khan? Thank
Yes.
you. So in the AG opinion, the last AG opinion, she states that it has been long-standing practice in Nevada that physicians only work as contractors for private hospitals and not as employees. To depart from this practice mark a significant change that would be tantamount to a change in state public policy. So that is the framework that a lot of us live with, is that the corporate practice of medicine law exists. And then when you find in statute that there's exceptions to the corporate practice of medicine prohibition, there's exceptions to that for research facilities and academic facilities, that's where I think we just need to codify that. And I think there has, according to what the Nevada Hospital Association's position seems to be, there has been slippage in that. So I would like to return to having a prohibition on corporate practice of medicine. And I think there's at least 30 states that do that. And I think that it's related to hospitals. Dr. Khan, I don't think it's related to individual physician offices, because individual physician offices can be self-employed all they want. And then I think your question about what's happening in managed care is a good one. So I have at least 3 assignments here, and I appreciate the consideration of this BDR. And I'm glad that we're at least talking about it, because you can see that the confusion needs to be clarified.
Yeah, thank you very much. Any other compelling thoughts somebody has till we move to the next one? Because a lot of homework needs to be done, like Commissioner Bond pointed out. So we need to do a lot of homework and crosstalk with various stakeholders, including the state and the laws, etc. So we'll have hopefully as much information as possible before our next meeting, so that we can have a more substantive discussion. Next, I think we should move to the next item. Melinda, what do you have?
Yes, we'll do. So the next one is, so this is the last of the 3 that received 4 responses. So this is subject to topic 6.
More than one with 4 responses, correct?
Yes, we had 3 topics with 4 responses.
So we'll go through all 3 of them. Go ahead.
Yes, so we just did the first 2. So this is the last of that batch.
Okay.
So this topic is to create a prescription drug affordability board, to expand on NRS 439B 630 and to set allowable rates for certain high-cost drugs identified by the board, create a health plan review board with similar function as above, but for commercial health insurance plans. So just wanted to open that item for discussion.
Who is the author or the 4 responses? Maybe they can chime in first to give their thought process. Any hands up?
None at this time. I know Commissioner
Yeah.
Winkler had a primary input on this topic. Commissioner Winkler, did you want to add any additional thoughts?
More if people had questions, I think it's fairly straightforward, and especially if looking at our BDR detailed overview and the information that's there. I guess just the thing that I brought up at the beginning that I feel that with the benchmark codification, including that primary care leg, it feels like these topics kind of have some similarities, and perhaps they could be combined. It's just an overarching affordability review that works off of all we're doing with the cost growth benchmark, the all payer claims database, all that stuff, our transparency legislation that we've done before. We can just kind of synthesize all of that and put it towards, it's a little bit more of a complicated BDR, but I think it touches on all the things that we've been discussing.
Okay, anybody else? Because I have a comment, but let others speak first.
Not seeing any hands raised.
So my thought process, I am very strongly in support of some kind of an oversight on the pharmaceutical drug costs. I know we addressed the insulin thing, but that was a small little area. It was very significant, but a tiny area of the Prescription Drug Affordability Board. It has to have some teeth, though. Just creating boards and commissions doesn't make a difference, in my opinion. And to look at the cost factors of the suppliers, the pharma, this has been going on at infinitum discussion at the federal level, and they've not been able to make any meaningful progress in this. So if the state is willing to take the bull by the horns and come up with some oversight on the cost effects basis, because we see every day in the hospitals and otherwise, the cost of certain drugs are astronomical. And those are the only drugs available, and they go into hundreds of thousands of dollars. And these are not occasional scenarios. This is a serious problem. Even everyday drugs, you guys go and buy a drug for cholesterol, the co-pays and deductibles kill the patient's affordability cycle for their monthly income. So I think, in my opinion, some kind of an oversight is important. Maybe the language needs to be tweaked based on legal advice and the state's input, but something has to be done. It's about time that we took this, as I keep repeating, bull by the horns and address it.
Thanks, Chair Khan. I do notice Commissioner Bond does have her hand raised. Please go ahead.
I just wanted to echo what was already said by Commissioner Winkler, and actually Chair Khan too. We do have pretty good data on the books in Nevada after 2 sessions, not just insulin, but other costs. But we don't have an avenue to really address them. I don't know what the cost of this would be, and I don't know how it competes with our other requests, but this is definitely germane to what we're trying to do with the cost benchmark stuff, like Commissioner Winkler suggested. It's like a direct result of what we're going to see with the new data as well. So I just appreciate it coming forward and the dialogue about it. I don't know how we're going to choose these BDRs, but they're all really good topics.
Thank you. Anybody else has comment?
Yes, Commissioner Roa Dugan, please go ahead.
Good morning. Thank you. I wanted to agree with the commissioners that spoke before me, and I would like to see if maybe legal or the professionals can show us how this topic could be combined with the first topic, with the benchmark, because that would be great. That would free us one BDR, since this seems to be around the same topic.
Okay, anybody else raising their hand?
I do see Michael Baylett, you have your hand raised. Please go ahead.
Thanks, Melinda. A couple of things, a question and information I want to share. On the prescription drug affordability review boards, there are other states that have these. And so if we want to think about what are the financial and operational implications of them, there is information available that we could draw upon. With respect to the Health Plan Review Board, Tyler, I wondered how this relates to the Division of Insurance regulatory activities and what you are envisioning here.
So currently we have, like the floor that the ACA created of unreasonable premium increases. Nevada right now requires prior approval by our Division of Insurance for individual or a small group rate change, but not fully insured large group plans. So that big chunk is missing. And it's only prior approval authority. And while they can reject or say maybe you should do something else, there's no affordability standards. There's nothing standardized. There's nothing set that patients can look at, that other payers can look at. So I think that would be more of an expansion of what our Division of Insurance is doing currently.
But you're thinking about a separate board as opposed to changing the practice of the Division of Insurance.
The only real example, I guess, is Rhode Island, and they seem to have created a whole other board that focused on this.
Yeah,
No?
so I work with Rhode Island,
Yeah.
and they do it within what's called the Office of the Health Insurance Commissioner. So it's part of the regulatory function. There's not a separate board per se.
Okay, so I think that probably makes more sense rather than creating another arm, but of course that involves speaking with another agency, a regulatory agency, and expanding their role.
Okay, thanks for clarifying.
Any other comments on this before we move to the next?
Yes, Commissioner Bond, please go ahead.
I'm sorry, come back to it, Dr. Khan. And is it possible from what you're saying, Commissioner Winkler, and the comments from our consultant, Michael Bailiff, is this something we could do without a BDR? Is this something we could add to the capacity of the PPC and the capacity of what we're trying to do with the benchmark programs in general, and do the work even if we don't have a way to do it? Do we need the BDR to do this work? That's what I'm saying. Is there other ways we can get the work done? I'd really like to do the work. I just don't know if we're going to have enough BDRs to get it all done.
So is there a response to that?
I see Director Whitley has his hand raised.
I just would offer that I think we do this quite often, where we do cross-program analysis of data and I think that the commission can task the department to pull this analysis out and to look at it from different lenses, like primary care, that includes everything. I mean, I would hope that we would do that, because I think the implications and the opportunities for strategies for improvement are better conveyed that way. So I agree with Commissioner Bond that perhaps this just needs to be a directive from the commission to the department.
Well, that sounds pretty good to me. Any other thoughts? Melinda, if not, should we move to the next one?
I am not seeing any additional hands.
Okay. The next item.
But I think Michael Bailiff is raising his hand.
I'm not sure that the creation of a drug affordability board is something that could be done without legislative action. I want to flag that. I'm not sure about the change of the insurance rate review process. That might too. I'm just a little skeptical that these changes could be done without legislative action. And I understand that you've got too many good ideas and you can only do 3, but I'm worried about creating a false impression that this action could be moved forward without legislative authorization.
Well, I think what we're asking, and I'm really glad that that Director Whitley was able to weigh in here. I think we're asking if the work can be done without a whole separate board, because I think there's a lot of pieces of data that we already have. So I would just like us as the PPC to explore, can the PPC pick up some of this responsibility, or can it go under DHHS's responsibility for oversight, because they do all the prescription drug stuff now? and
I'm
not
saying,
in
so
the absence of
allowable
a
rates,
whole separate board.
yeah,
But I also-
allowable rates, but that it would be, that's
Can I finish? Can I finish?
yeah, I'm sorry.
I think that we should get some legal counsel though, Melinda, if possible, so that we can understand where the red lines and blurry lines are. I'm more worried about the work than the board itself. So I understand what you're saying. I just think that we need more help on this.
Yeah, that makes sense, Commissioner Bond. I can look for legal assistance on that. And then I also noticed, Beth Slamowitz, you have your hand raised.
Yeah, thank you. I just wanted to just add a couple of caveats just based on my knowledge of the boards in other states and kind of what some of the expectations and also requirements in terms of what is needed for these boards to function. Most specifically, the board definitely needs access to what we call drug pricing files. And those usually are subscriptions that are required and are required to be paid for, and they are very specific in terms of their use. And that allows access to drug prices. There's First Data Bank, there's Medispan, some of those which you've probably heard of. And so, you know, while the work can be done, there are certain things that would be required to have access that do have costs to them. I know somebody mentioned, I think it was Michael, that, you know, other states have put these boards forward. And so, you know, if you go out and you look at those bills that were passed to create those boards, a lot of them do have their fiscal notes attached in terms of the cost. I had sent some information, I think, over to Melinda upon request. I don't know if that was included in the BDR summaries, but just for example, for Colorado, you know, their funding was just under $1 million due to the requirements for some of the technical pieces, as well as for the resources. I think they had 5 FTEs. Most of these fall under the Division of Insurance in terms of being able to monitor and manage the work. So I just kind of wanted to add a few of those caveats. The other thing that I wanted to add just for informational purposes is that a drug affordability board from a high level don't impact list prices of drugs. They really are there to help manage the cost for insurers and purchasers in terms of the cost that eventually comes to the consumer, right? So a lot of times because of the high drug prices, we see premiums change, we see co-pays change and things like that because they're trying to manage those costs. And so it does allow potentially for some of those costs to come down for the consumers if we can set some of these upper limits for these high dollar drugs. Most of the states that have put the boards in place have set limits, you know, for high cost drugs, you know, around $30,000 plus per year for treatments. And so those definitely are high dollar drugs that treat a particular or a smaller population of people, but still have large impacts in terms of healthcare costs. So just wanted to add some of those caveats and information, and obviously I'm here for questions if anybody has them.
So I appreciate that. I think Richard Whitley has some work cut out to let us know, like Commissioner Bond mentioned earlier, to come back with us with some thoughts, what can be done without a BDR, what cannot be done without a BDR. And then we can look at it at that point at our next meeting.
And I did just want to note also for all the commissioners that the comments that Dr. Slamowitz had mentioned about this topic were included in that detailed BDR document that you all have.
Yes, that's true. All right, thank you, Melinda. Moving along, we have to keep in mind our time restraints. So should we move to the next item, Melinda?
Sure. Okay. And so those so of the higher response topics, we have 5 out of 15 that were the higher response topics that had, you know, responses with 5 responses and 4 responses. So we do have a topic with 3 responses. However, I am asking to potentially set aside those topics that had only 0 to 2 responses to discuss at a later time. And just wanted to open for discussion on that proposal.
I think as a priority, going up to 3 makes sense. And then depending on, because out of all these that we have discussed, we are potentially going to get approximately 3 at the most. And then if we have time, we can always go further down the line if there is no consensus on the top three, which it looks like generally at this point, based on preliminary information, there is some general consensus till more specifics are available at the next meeting.
Correct. And Vice Chair Rubelay, please go ahead.
I was just going to ask what the plan was to get from 5 to 3. That might be important before we deliberate on setting aside things.
Sure.
So that from 5 we go to 4, and then from 4 to 3. So there are a couple in the 5 category, and there are a couple in the 4 category, 2 or 3, I guess. So that already takes us to the top 5, and then it brings us to the three responses.
So are we going to do another poll, or how do we get from 5 down to 3?
We will have to do that, obviously.
Mhm.
We will have to do that so there is more consensus or majority in favor of the top 3. And that's the whole idea of this exercise we are doing today, to start narrowing things down.
Yes, excellent. I figured we would do another poll and then we can present the results at another meeting and yeah, move forward from there.
Absolutely. All right, Melinda.
Okay, so we'll move to the next slide. Okay, and basically I think we just discussed this. So having seen the results, are there any other final, discussion, clarification, just any general thoughts open to your discussion, commissioners, and just want to get the most that we can out of this discussion point. And I do see Commissioner Mcallister, you have your hand raised.
Yeah, so I love doing the polls, and I know we need to do work between meetings, but I did have a concern that because it was anonymous in the way it was set up, I could have completed it 12 times. And I'm not okay with that. I think the poll, if it really is going to focus our discussion, it needs to record who's voting, even if you don't share it publicly, and limit 1 vote per commissioner.
I think
Absolutely.
At some point we have to have some honor system. Somebody filling in the same thing there 12 times. I think that would be a little too much.
Yes, absolutely.
Notice if there were 20 responses.
Yeah, Michael, I want to defer to you. I think that we can do what Commissioner Mcallister is proposing, correct?
Yes, and I want to assure you there were only 9 responses, so nobody appeared to have voted 20 times.
Yay.
All right, next, Melinda, moving along.
Okay. Now I wanted to talk about the August meeting plan. So I wanted to give the opportunity for you all to meet more than once in August. So currently our scheduled PPC meeting in August is going to be Wednesday, the 17th. And as you know, we need to have our BDRs no later than September 1st. So I wanted to open the opportunity to have more than one meeting to finalize these BDRs.
Okay, Melinda, before we go further, by August, we should have narrowed things down. We should have had answers to what we just talked about this top 5 responses. Hopefully we've had legal tweak it, the DHHS look at it, and narrow down. I would like to allocate the maximum time at our next meeting to narrow things down rather than putting into a crunch and adding another meeting. I think if we are going to narrow down our discussion primarily on the 5 topics to narrow them down to 3, then we should be able to accommodate all that in one meeting as long as we don't add other items in that meeting, because I don't see any compelling agenda item that has to be looked at in August other than the BDRs.
Correct.
So I think we'll allocate a maximum time for the next meeting for this particular subject to hammer down every specific thing, because once we have done our part, legal will again tweak it. And that can come back to us before the 1st of September meeting if there is additional tweaking. I'm hopeful that they would have tweaked it enough to get the correct language, avoid duplication of items in the BDRs, and consolidate the subject matter in 3 BDRs if that is possible.
Thank you, Chair. I do notice Commissioner Bond, you have your hand raised.
Yes, I might have been after Commissioner Mcallister though, but this is just real quick. I might have missed what you both said about the deadlines. When do these BDRs have to be to LCB?
By September 1st.
Okay.
Yeah. And Commissioner Mcallister?
Hi, thank you. So I'm certainly open to having extra meetings. I know August can be tough. People have vacations. I have a conference I'm going to in Chicago. But I also don't feel like I need them. I feel like I'm ready to vote already, just myself. So I don't know how the other commissioners feel.
Yeah, it seems to me, listening to all of you folks, that there's general consensus on the essence and the gist of these BDRs. Now it's a matter of some specifics and legal tweaking and DHHS looking at them and avoid duplication. And if we can narrow those down enough for these 5 topics by next meeting, then I think we should be able to wrap it up. Keep in mind, even after we make our final recommendations, Legal and Legislative Counsel Bureau will further look at it and may tweak it further. And it'll come back to us as an FYI after the legislative people have looked at it.
Correct. And Commissioner Bond, I see you have your hand raised.
Yeah, I wonder, since we're down, and again, I missed the beginning, but it seems like if we are down to 5, and I understand what's being said about, it's hard to discard the rest when a lot of them are really valuable. But if we are down to 5, I wonder if we could also add the work that we just talked about with the Drug Affordability Board. Are there pieces of the others that could be implemented or taken on by the PPC without a BDR so that we get the work done, even if we don't have the legislation to do it? I'm saying that, again, I think we need legal to review, but I remember last session, we had, and we could have others on this commission weigh in on this. We have quite broad powers. This commission has very broad powers. So there might be things that we are able to accomplish in these BDRs topics if we can't get them into BDR. So I would like us to make sure we add the analysis of, can this work be done anyway, even if it doesn't make it in? And that might help us consider the priorities for things that have to have a BDR.
I think that's a great idea, Commissioner Bond. I think the DHHS people can look at it and let us know, given, like you mentioned, the authority of this commission, if we can separate some of these out under that authority, that may give us a little bit more room in the BDRs. Any other comments?
Let's see. I'm not seeing any other hands raised.
So let's keep to the next meeting, and hopefully everybody is on top of it to give their input from the departments, legal and DHHS, and the legislative people, if at all, they are going to chime in after our finalization so that we can, before September, narrow these things down. I mean, just in case there's reason that this is not wrapped up in our August meeting, we can always hold an emergency meeting. I don't foresee that happening based on our discussion today.
Excellent. And then Dr. Tyler Garner, did you have a question?
I think I did have a clarifying question. Because the next meeting will consist of a review of the top 5 and the additional information that was requested today, I just want to be clear about the additional information or considerations that will be provided. And so I thought I heard something around or I know I have the request of, can we determine if there are other commissions, committees, or legislators potentially carrying some of this legislation as a part of the process? 2, any fiscal considerations as a part of the discussion. And then 3, the piece around, are there some, they might be combined with a recommendation to combine the first one and the pharmacy board, particularly if that work can't be undertaken under the auspices of this committee or by HHS.
Right. You raise you raise a good point. So that is what we are hoping, that between DHHS and the legal can look at all these aspects and whether we need to, as I use the word, consolidate some of these together, and those cannot be consolidated, whether they would be appropriate under the commission's authority, like Commissioner Bond has alluded to. So all these aspects will be looked at before our next meeting.
And I just wanted to clarify, Chair Khan, before the next meeting, will we be running a additional poll on these 5 topics, or will we be discussing all 5 and formally voting in the August meeting?
I think what needs to happen based on our past experience, that if we can get the feedback from the appropriate departments prior to the meeting, prior to releasing the agenda, if you can share that final recommendation of language with the commissioner so they'll have access to that, then we can deliberate on the 5 items in the next meeting, and it'll be hopefully more efficient, since the language would have been distributed, and if somebody has a problem with some language, legal will be on the meeting, hopefully, to answer those questions. And so would be the DHHS to answer their questions, so that we narrow our discussion to any final tweaking of those BDRs.
Okay, sounds good. Thank you.
Okay, what's the next item on the agenda?
Just really quick, I did know, Chair, Commissioner Bond, your hand is raised. I want to make sure if you had anything else. Okay. Okay, we can move on to the next item.
All right. So the next item I have is more detailed discussion on regarding cost growth mitigation.
Yes.
Is that correct?
Yes, I will turn it over to Michael Baylett.
Michael, you have half an hour.
Okay, thank you, Chair. Hi, everybody. So you might want to stretch or stand up as we transition topics. We're going to pick up on a prior conversation that we had where I shared with you what were examples of cost growth mitigation strategies that some other states with cost growth benchmarks are pursuing. When I shared with you that range of strategies, you express interest in learning more about them. And so for today's meeting, we're going to do a deeper dive into just one of them. The intent is not for you to make a recommendation to pursue it or not, but simply to help you develop a more detailed understanding of the strategy. So the strategy we're looking at is actually 2 strategies, but they're related, so we've grouped them together. And those strategies are provider price caps and provider price growth caps. Similar but different strategies, as I will explain to you. As I go forward, please feel free to raise your hand at any point in time if you've got questions or reactions to the information that I'm sharing. So the reason for the focus on this strategy in other states has been, we know that provider prices, as opposed to growth in service utilization, has been a leading driver of spending growth for individuals with employer-sponsored insurance. And this comes from a report by the Healthcare Cost Institute using national insurer data. We saw some of this during our April meeting when Kyron Morgan presented on data for the Medicaid program. Overall, the Healthcare Cost Institute reported spending growth of 9.3%, with utilization actually decreasing, but prices growing 16%. And increasing prices was found across a number of service categories: hospital, inpatient, outpatient, professional services, and prescription drugs. All right, so this is the why for thinking about prices. So what's a provider price growth cap? I'm going to explain these 2 concepts. So a price growth cap is a regulatory limit on how much insurers can increase payments to providers annually. Now, it can only be applied to insurers for their insured business. We know that in Nevada that most commercial insurance business is self-insured. Limited experience in other states is that where this has been applied, that the insurers have applied it across their what's called book of business. So they've applied it to both their insured and self-insured, but technically they can only limit for fully insured. So this is a limit on how much insurers can increase payments year over year to providers. This can be applied to certain classes of providers where price growth has been problematic. In the 2 states where this exists right now, it's enforced through insurance regulation. Provider price caps are a little different. This is a limit on the absolute level of provider prices. So it's capping how high prices can be at the high end. And it's really focused on higher end outlier prices. It can be applied in a number of ways across the full commercial insured market for just out of network payments, where sometimes high prices are particularly problematic because they're not subject to insurer fee schedules. They can be applied within public employee benefit programs such as PEB. And I'll share with you a couple of examples of states that have done this. It can also be applied within a public option. So this is a range of different types of application. And so the implementation can be through public purchasing authority and or through insurance regulation, again, depending upon how it's applied. So why do this? I've intimated this a little bit already by talking about prices. Provider prices, as I noted, are the primary factor driving healthcare spending growth nationally and in most states. High prices certainly hurt consumers. They increase out-of-pocket spending. They indirectly increase premiums. And we know they harm access to care because we know that when individuals have higher out-of-pocket costs, they don't access care as much. There's lots of research going back decades showing this. So bigger deductibles, bigger coinsurance, co-payments, all of this results in people self-limiting their access to care, including needed care. This strategy can promote pricing transparency. And we know that right now, provider market pricing is sometimes described as dysfunctional because there's huge variation that exists across providers and across payers, actually regardless of the provider market. And finally, this could be used to redirect spending to under-resourced sectors of healthcare. So one state that's implemented this policy, Delaware, used this strategy, and it was price growth caps, as a rationale for increasing investment in primary care. And they set a primary care spend obligation that increased primary care spending as price growth for other services were limited in terms of the annual rate of growth. So what's the evidence for these two strategies? There's not a lot, but there's some. In terms of price growth caps, there was a control study that was published in Health Affairs 3 years ago that looked at Rhode Island's price growth cap, which has been in place for several years. And they found that commercial spending grew at a much slower rate in the commercial insurance market in Rhode Island compared to a regional control group of states. So this is a pretty robust evaluation. The other state with the price growth cap, Delaware, implemented the program only recently, so there's no evaluation evidence of it yet. In terms of price caps, we've got two examples to look at. The state of Montana implemented price growth caps for its state employee health plan in 2016. They limited hospital prices to a multiple of what Medicare pays. And they reported savings of about $48 million across inpatient and outpatient services for the first 2 years, so 2016 and 2017. The other state that's implemented price caps is Oregon. Its legislature passed a requirement that for their public employee benefit program, actually programs, they have two, that they cap in-network and out-of-network hospital provider payments at a percentage of the Medicare rate with some hospital exemptions. While we don't have a figure here informally, Oregon has reported to me in conversations that I've had with them that they also achieved savings through their price caps. So again, these are high-end caps on a limited number of prices that are high relative to the prices that are being paid to, in this case, other hospitals, although this doesn't not have to be applied to hospital services per se. Leanne?
Just a clarification, as a percentage of Medicare rate, it was over 100% of Medicare though.
Oh,
correct?
yeah. Oh, yeah. So commercial rates are way, way above 100% of Medicare. They're usually well over 200% of Medicare.
I just wanted to clarify for people who weren't healthcare administrators.
Yes, yeah, right. So these are two states that have done it. They've reported savings. They've just done it in their public employee health plans so far, which was just one of 4 examples I gave of how this could be applied. Any other questions about these strategies in concept or about these 3 state examples I've shared? All right, so next I'm going to share if Nevada wanted to pursue these strategies, what steps might it take? And in this case, I'm going to draw from an implementation guide that our firm recently created for the Commonwealth Fund that they will be publishing for states in the next few months. And so that's the basis for the guidance that's laid out on the following slides. Oh, I'm sorry. There's also modeling of federal proposals of the benefits of price caps in terms of savings. I'm not sharing that though. I think the state examples are more relevant. Okay, so 3 general steps: setting the stage, designing key model components, and how to ensure model success. So first, setting the stage. Generally, if you wanted to recommend that this be done, there would probably need to be a stakeholder structure created to advise on the design of the program, be it a price growth cap and or a price cap. You could do these 2 strategies, by the way. They are complementary, although the examples I gave you were of states that did one and not the other. I just want to note that they could be done together. So, recommendation would be to have stakeholders advise or have the opportunity to provide input on the design, especially those that would be impacted by the price growth caps or the price caps. And then to communicate publicly with the public at large about the policy development process and create transparency for it. Next, for centering the stage, we recommend consideration of equity. So equity is equity for providers who would be affected by this. Also equity for communities, urban and rural, and also equity for patients. And to think about this upfront during the design process, and to consider this when determining who should be engaged in the stakeholder effort to advise the design of the program. Next, it's necessary to think about the design decisions to create the price growth cap or the price cap. So a first step is to understand contribution to spending and spending growth. And you got some initial insight into this at the April meeting when we showed you some initial cost driver analysis for Medicaid and PEB. And so more specifically, it'd be helpful to know where is spending growing fastest across service categories, and of course, where is it growing fastest in terms of price, and also what does price variation look like across service categories? And these are examples, but certainly you could look at other definitions of the service categories. But understanding where prices are growing fastest and how variable prices are is really a necessary precursor for deciding upon a price growth cap strategy or a price cap strategy. Then it will be necessary to determine whether this is a broad commercial market strategy, a purchasing strategy for public employees or for a public option, or something focused on out-of-network care. And the price cap is really specific to out-of-network care. For additional design decisions for the price growth cap, it can be tied to an economic indicator. So just as we establish the cost growth benchmark by linking it to 2 economic indicators, so too could this be done for the price growth cap. So the 2 states that have this strategy, Rhode Island and Delaware, have used measures of inflation. So there are a few options laid out here. CPI, which you're familiar with, core CPI, which removes food and energy, which tend to be particularly volatile. Personal consumption expenditures, which is a broader price index, not focused so much on consumer out-of-pocket expenditures, and one that is embedded in our benchmark calculation. Medicare also publishes a series of market baskets to track inflation specific to healthcare prices. These other examples, CPI, core CPI, and PCE, are not specific to healthcare. The Medicare market baskets are. So determining whether to tie to an economic indicator and which one is a relevant design decision. For price caps, there's a question of whether to link the price cap to Medicare, which is what Montana and Oregon did, or to pick a commercial standard. So what do I mean by commercial standard? You could say that the cap should be no more than X% of the commercial market mean or median. Okay, instead of linking to Medicare. Why might you want to do that? Well, Medicare is a little problematic for certain services. Medicare does not cover OB services, for example, and doesn't pay for a lot of pediatric care. So there are problems using Medicare. Can you figure out how to make adjustments to using Medicare? Yes, you can. Oregon and Montana had to do so, but there certainly is a case to be made for considering using a commercial standard. Regardless of whether it's Medicare or commercial standard, there's a question of at what percentile the cap should be set. So Leanne asked, is it 100% of Medicare? No, it's not. So if it's going to be, above Medicare, is it 210, 230, 275? Where to set the line? That's a question. And whether to set a floor. And what do I mean by that? Well, oftentimes if you set a cap, you can create an unintended consequence of provider organizations requesting of the payers that all their rates be at the cap. And when you do that, you may actually wind up spending more rather than less. So, so what is done sometimes is to say that there's some floor mechanism that doesn't allow prices to grow, so they go up to the cap. And this is where putting together the price growth cap and the price cap as part of one strategy works well, because you then you don't permit prices to grow dramatically up to the cap level. Okay, regardless of what's done here, there also needs to be consideration of how often there is an opportunity to modify the program design over time, and whether to have a transition period or a phase-in period for the strategy. Tiffany, I saw you had your hand up.
Yes, just a quick clarifying question. Are there some inherent benefits or downsides to either pegging it to the Medicare commercial standard?
The biggest consideration is the one that I mentioned for Medicare, that it doesn't work well for OBGYN services and for pediatric services. And sometimes sometimes Medicare pays at levels that are sometimes they can be much better than for commercial. I mean, not often, usually they're below, but for some services they can be above. So you have to smooth out some rough edges if you use Medicare, which you don't have to if you use commercial. But Medicare is a really easy reference, because in order to do the commercial standard, if you're going to do it on a statewide basis and you don't have an all-payer claims database, you've got to figure out how do you establish the commercial standard, or do you have each insurer set their own commercial standard, which gets a little messy. So there are some attractive parts of using Medicare because everybody knows what the Medicare fee schedule is. It just doesn't work perfectly when applied to commercial. So one way or the other, you have to do a little bit of work to make either model work. Is that helpful?
Thank you.
Sure. So there's another design decision is you apply a price growth cap to each provider contract or across all the payers contracted providers. So for example, do you tell an insurer none of your provider contracts can grow more than the price growth cap, or your hospital prices taken all together, do a weighted average across all your hospital contracts, can't grow more, which means maybe some hospitals can grow more and some can grow less. In Rhode Island, it's applied to individual hospitals. In Delaware, it's applied across all the insurers' hospitals. There's the compliance monitoring of the latter, I mean, doing it in aggregate across all of an insurer's contracted providers is much more complicated. It's much easier to do it if you apply the price growth cap to every provider contract, be it hospital or professional or however it's defined. And the price caps can also be applied to individual services or an aggregate across all services delivered by a provider. Again, if you do it in aggregate, it's harder to do compliance monitoring and make sure that the insurer is doing it the right way. There's also a question of whether to incorporate quality and other performance incentives. In Rhode Island, they've integrated a quality improvement requirement into their price growth cap. That doesn't have to be done, but could be done. And then there's a question of, are the quality measures left to the payers and providers to negotiate, or are there a standard set to be applied? These are just questions. I'm not suggesting an answer, just saying they're questions to be considered. Then there's a question of what do you do if there are pre-existing payment disparities? Because there are pre-existing payment disparities. We know there's tons of variation in pricing that exists. So if you create a growth cap, you're sort of locking into place those price differences. And maybe that's okay, or maybe from a public policy perspective, that doesn't seem okay. So Rhode Island, after a few years, allowed a one-time adjustment for the providers that had the very lowest commercial rates and allowed them to come up higher than everyone else could. It was a one-time. Again, I'm not recommending this. I'm just noting that once you put a price growth cap in place, everyone's going to grow from whatever their baseline is. And those baseline levels will be different. All right, then finally, there's how do you make sure all of this works? I mean, this is described here as oversight, but there needs to be some level of compliance activity after you establish the program. One consideration is to make sure that you consider the potential for gaming, and all strategies are subject to gaming. So if you create a cap strategy, either price cap or price growth cap, there's the risk that the response will be to grow utilization to compensate for lower price growth, to increase prices where they're not subject to the price growth cap or the price cap, to change coding to increase prices per unit for risk adjustment purposes, or as I noted earlier, to have the ceiling become a floor with everyone trying to move their prices up to the cap, right? These are all logical actions for any provider organization to take in response to the creation of a price growth cap or a price cap. There needs to be some analysis to support all this. So I talked about identifying drivers of cost earlier on. There needs to be some modeling of what the impact of these strategies would be. If it's applied to hospitals where they have been to date, or to other providers, and there is some consideration in other states of applying these professional services, there needs to be some process to make sure that they're not jeopardizing the financial health of the organization. And then there needs to be some there needs to be some assessment of impact on spending, quality, access, and patient experience. That can be done within the state using available resources, or there could be an independent evaluation as was done for Rhode Island. So in summary, this price caps and price growth caps can be highly effective in slowing cost growth, but they're not for the faint of heart. But I want to note that that price caps and price growth caps have an impact on spending right away. You don't have to say we're going to implement this and hope that in 5 or 10 years it's going to work. You know right away it's going to have an impact. But not for the faint of heart, because this is hard to pull off. Why? Because what provider organization would ever want to be subject to a price cap or a price growth cap, right? Because it limits the ability of provider organizations to grow their commercial revenue. And that's where this is being applied, is in the commercial market, if that wasn't totally clear. So a few questions for you to consider. Is this something you think that Nevada should consider, one or both of these strategies? Why do you think so? And do you require any additional information as you consider this policy option? As I noted earlier, we're not asking for a recommendation and certainly not a vote today. We will do deeper dives into some of the other strategies in future meetings so that you can consider them all together. This is just one. But based on what you've heard from me today, what thoughts do you have in response to these questions? So I'll pause there.
Thank you, Mike, and I appreciate you staying within the time. My personal recommendation is that when we have all the information together, we consider that some of our future meetings so that people have time to digest on these questions that have been raised. So once everybody has digested and had put their thoughts together, they can come up with those suggestions at the next meeting when you have additional information also to consolidate the information. So that would be my thought. So I think we should stop that at this point. But let's see. Our next item on the agenda is public comment. Melinda, any public comment in the north or south or in writing?
Chair Khan, if I might, I just wanted to request quickly of the commissioners with regard to the stakeholder subcommittee, if there are any gaps that you've noted, if you could please just send those to me, and open and willing to take any opportunity for improvement there. And then we can officially vote on that stakeholder subcommittee next month. So just wanted to put that on your radar. Please send me any comments on that. And then Commissioner Bond, do you have your hand raised?
I do. Thank you for saying that. Thank you. I appreciate it. I think that we'd like to think about that stakeholder group, but honestly, I'm glad you're saying this, because I think everything you just presented, Mr. Baylett, you raised the name stakeholder over and over again, and now I'm not sure if it's the same stakeholders. Are we talking about, I think that we need to think about what this stakeholder group that you talked about when I wasn't here early, but I've seen the list. Melinda, how that compares to everything you just raised, Mr. Baylett, about stakeholder input. And I don't know if it's the same or if there's an additional stakeholder process we need to create.
So my thought is, it's too early to say. It could be the same, or you might decide, for example, that you looked at spending and all of the price variation in growth is in, I'm just making this up, it's in orthopedics. Okay, if that were your focus, then you would need a different stakeholder group, right? So I would say it's too early to determine what would be the right stakeholder group at this point.
Also, I think we don't need the stakeholders meeting to become 50 people because then it doesn't accomplish anything.
Well, if I may, I agree. I agree that we shouldn't have a stakeholder group that's too big to do anything. And I agree that stakeholders that really want to express an opinion that maybe isn't what the PPC is otherwise going to hear, I think it's important. So I appreciate the work for the stakeholder group. I'm not sure, given today and actually the way the first one was formed, that that I feel like it's complete. So I appreciate the opportunity to add members or consider gaps this month, and then tell us how you want to proceed next month to be able to complete that and vote on it if there's any specific steps we should take. I definitely appreciate more time on it.
No, I agree with you. I had mentioned in my earlier remarks on the stakeholders meeting, I'd asked the question of the commissioners, you missed that obviously, that if anybody had any other entities that they want represented on the stakeholders meeting. So that still holds open. And if you have any other entities that you think need to be represented, there should be. My only point is we don't become so huge that it's not manageable. We are at a reasonable number right now, so we have room for additions of other entities' representation.
Okay, thank you.
And
okay.
then Commissioner Winkler?
Sorry, very quickly, I just wanted to clarify what is the charge of the subcommittee, because up to this point, it's only been to advise us on the healthcare cost program and the cost growth benchmark, but I feel like the PPC is really kind of expanding. So is this subcommittee still only focused on that?
You mean the advisory stakeholders committee?
Correct.
Yeah, the stakeholders committee, as set up previously, and this time is evolving, is that various stakeholders who are not represented on the commission may have an opportunity to give their input as a subcommittee of this commission. And whatever they come up in that, it can come back to the commission to look at it and deliberate on it and see whether we need to act on it or not act on it. So the idea was they will do some of the homework that normally we'll end up calling these so-called experts to all our commissioner meetings, prolonging our meetings indefinitely. This way, all the stakeholders are there and they can give their input and deliberate as much as they want and come up with some consensus, understanding that we like the commission to look at A, B, C, and D from their perspective. And then we can choose to look at them or not look at them.
Chair Khan, I did want to clarify, though, this subcommittee that we are discussing, the main goal of this subcommittee is to provide recommendations to the PPC on matters related to the Peterson-Milbank program for sustainable healthcare costs and the healthcare cost growth benchmark.
That's correct.
And then Commissioners Bond and Winkler have their hand raised. Commissioner Bond, please go ahead.
I'm glad you stated that. I think it's more than mostly. I think the stakeholder committee right now was formed specifically to support the work that the growth benchmark group was doing, and I don't believe they have a role outside of the benchmark. So I want to make sure I understand that as we think about the rest of the structure.
No, I should have clarified that. I agree. That's the bottom line.
Yes, I agree.
Okay. Should we proceed, Melinda? Next item, any public comments?
Okay, anyone with public comment, please press *9 to raise your hand. Looking for public comment. And seeing none, Chair.
Okay, so if we have no public comments, we'd like to wrap up the meeting for adjournment. I'm glad everybody we accomplished a lot, believe it or not. The BDR discussion can be very intense, which it was, but we were in good timing. So I really appreciate all the commissioners' time and their indulgence in this whole deliberative process. Thank you very much, everybody.
Thank you. Thanks, Chair.
Thank you.